Hey guys, welcome back to my channel, The ENT Resident. Today, our topic of discussion is going to be differential diagnosis of nasal mass. Now, this can be relevant to you in clinical scenarios as well as in theory questions. Sometimes in theory questions, you get a long question where you're given a case like say, for example, a 50-year-old male presents with a nasal mass and with complaints of obstruction, sneezing, etc., etc. How would you approach the case? Basically, the knowledge that is being tested here is what are the differential diagnosis of a nasal mass when a patient presents like this. What would be the possible conditions that you would be thinking about, and how would you differentiate in between these conditions based on the clinical appearance, based on certain specific history questions? So that is one aspect of it. And whereas in also your practicals and your clinical scenarios, nasal mass is a very, very, very common case that you get. And here I will first be telling you what is the differential diagnosis, how would you classify them, and once I've mentioned all the conditions, I'll briefly talk about what is the clinical appearance of the nasal mass in each of these conditions. This video is not about discussing each condition in details over here. That is something that I'll be covering in another video. Here, I'll just be talking about the clinical appearances of each of these cases. So let's get started. So, first of all, let's divide them on the basis of a group of causes. For example, the first group would be congenital. Second group is inflammatory, where the basic cause behind is the inflammation. Second is tumors. Third is tumors. Fourth is granulomatous diseases. Fifth is fungal sinusitis. And last of all, miscellaneous causes. So, first, in congenital causes, there are causes like glioma, meningocele, encephalocele, meningoencephalocele. Then there is inflammatory causes, which will be two types, antraquinal polyp and ethmoidal polyp. Then coming to tumors. Tumors can again be subdivided into benign tumors and malignant tumors. So, in benign tumors, you can have papilloma, which can be squamous papilloma or inverted papilloma. Then there's hemangioma, which can be capillary hemangioma, cavernous hemangioma. Then there's angiofibroma, schwannoma, chondroma, meningioma, pleomorphic adenoma. Coming to the malignant tumors, there can be squamous cell carcinoma, which is the most common tumor. Then there is adenocarcinoma. The adenocarcinoma is something that you get more commonly in people associated with woodworkers. Then there's adenoid cystic carcinoma, malignant melanoma, esthesioneuroblastoma, and hemangiopericytoma. Next, moving on to the granulomatous diseases. This is a huge topic of discussion that I'll be doing in another video. Now, granulomatous diseases can be specific and non-specific. Non-specific ones are vaginal granulomatosis and sarcoidosis. Specific ones can again be divided based on the cause into bacterial and fungal. The bacterial ones include rhinoscleroma, tuberculosis, leprosy, and syphilis. And the fungal causes include rhinosporidiosis, aspergillosis, and mucormycosis. Next, coming to fungal sinusitis. Within fungal sinusitis, it is the allergic fungal sinusitis which can present with a nasal mass. And last of all is the miscellaneous causes like hypertrophied inferior turbinate, rhinolith, and maybe something as simple as just a blob of mucus, which may seem like a nasal mass from outside. So, this is the whole range of causes. And within the causes, as you can see that I've subdivided them into a lot more. So, this, if somebody had to first talk about what is the differential diagnosis of nasal mass, approaching it cause wise would be very good, because then once you have grouped the big categories, then you can subdivide them into the particular causes. So now we'll be discussing each one of these causes and what is the manifestation that you see in each one of them. First, we'll talk about the congenital causes. So the first congenital cause is glioma. Now, first of all, what is glioma? Glioma is basically a tumor like formation or a mass that forms consisting of glial tissue. Glial tissue is basically brain tissue. So, glioma is basically an ectopic mass of glial tissue. Now, you may say that encephalocele is also something that is containing the brain tissue. Then, how is it different from glioma? So, what happens in encephalocele is that in encephalocele, you see a herniation of the brain and meninges, which happens through a skull defect, skull bone defect. Whereas here, the connection to the brain is still maintained. It is only herniation of the brain tissue. Whereas in a glioma, the connection between the brain tissue and the mass that gets completely obliterated, leaving just the tissue. You can see in the image over here, this is the glioma. You can see this is the brain, and it has protruded from here, but then this bony structure shuts off over here. So there is actually no connection in between the glial tissue, the glioma, and the brain tissue. So that is the difference between an encephalocele and glioma. Also, although as I've just mentioned that this connection gets obliterated, in very few cases, maybe in 15 to 20% cases, sometimes a fibrous stalk may remain, but that is quite rare. Next, we'll talk about what are the different types of glioma. You'll see that in about 60% cases, the glioma is an extranasal glioma, whereas in 30% cases, you'll find an intranasal glioma, which means within the nasal cavity. And in 10% cases, it can be mixed, which means that it will have both an extranasal and an intranasal component. Now, you can see in the picture, the first image over here, that this is an encephalocele. You can see how the brain tissue is herniating through a defect in the skull base and entering the nose. So, this is what is called an encephalocele. An extranasal glioma is a second image over here. You can see there is some glial tissue which has come down to the nose and it is presenting externally. However, what happens here is that the bony communication completely closes. Unlike here in encephalocele, you can see that the bony communication, there is a defect and the bone is not continuous here. Whereas over here, the bony communication is complete. So this is an extranasal glioma. And how does an extranasal glioma present? It presents as a firm subcutaneous swelling on the bridge of the nose or on the side of the nose, or it can be near the inner canthus as well. If I had to show you an image, this is what you would see. You can see here, this is the extranasal glioma. You can see how it is involving the bridge of the nose, the side of the nose, and it's somewhere near the inner canthus. So these are the possible scenarios where it comes out, possible sites where it comes out. Next is the intranasal glioma. Now, an intranasal glioma happens when this comes down right into the nasal cavity, as you can see over here. And this nasal mass will be something that is firm, it is non-compressible, non-pulsatile. And a very important distinction is it does not enlarge on crying or straining. When the baby cries or strains, it does not enlarge. This is known as negative Furstenberg sign. This is what will help you in differentiating, this particular sign is what will help you in differentiating a glioma from an encephalocele clinically. And this intranasal glioma will also not transilluminate. So, this is the description of an intranasal glioma. It is a firm, non compressible, non pulsatile swelling which does not enlarge on crying or straining, and it does not transilluminate. Next, we move on to the second congenital swelling or the second congenital nasal mass, which can be the meningocele, encephalocele, or the meningoencephalocele, depending on which part of the brain tissue, if with meninges or without meninges, has herniated into the nasal cavity through a bony defect in the skull. I've shown you in the image over here how there is a bony defect in the skull over here. And this is through where either just the meninges comes down and herniates into the nasal cavity, or it can be brain tissue along with meninges coming into the nasal cavity, and that is what is known as meningocele, encephalocele, or meningoencephalocele, depending on which part has come down. And if you had to look for its description, this mass will be bluish and soft. It'll be compressible because this is a herniation. So the mass can, on pressed, can go back. If the bony defect is big enough, this mass can go back up, and it is a translucent mass. And the differentiating sign over here from a glioma is the Furstenberg sign, which means whenever the baby or the child will cry or cough, that is on straining, the mass will enlarge, increase in size, and this swelling is also trans-illuminating. So, this is the difference between the two congenital nasal masses. One is glioma, and the second one is the meningoceles. Next, we move on to the inflammatory causes. So, the two inflammatory causes that I've mentioned are the antrochoanal polyp and the ethmoidal polyp. So, let's discuss about the antrochoanal polyp. So, you can see in the image over here, if I had to describe this image, it is a solitary, pale or grayish, glistening, soft mass which is present in between the septum and the inferior turbinate. You can see that it has a smooth surface. These kind of swellings will usually be mobile. It will be insensitive to touch on probing. It will not bleed on touch. What does that mean? It will not bleed on touch. It means that it is a relatively avascular mass, and the probe can be passed all around the mass. And on posterior rhinoscopy, you will see a globular smooth mass in the choana. Now, this is the description of an antrochoanal polyp. And I will tell you just in a little bit how you can see it is very different from an ethmoidal polyp. And an antrochoanal polyp is usually originating from the maxillary antrum. So you have to remember these very important parts. It is solitary, it is a glistening, soft mass, it has a smooth surface, mobile, insensitive to touch, does not bleed on touch, and you can pass the probe all along. Next, we move on to the ethmoidal polyp. You can see in the image over here, compared to the image I showed you just before, you can see multiple grape like structure over here. So, an ethmoidal polyp can be described as first of all, the first difference is the ethmoidal polyp is usually always bilateral. So, there will be bilateral, multiple, pale grayish white, soft masses which appear like a bunch of grapes. You can see how this is appearing like a bunch of grapes over here. And the rest of it is the same description. It has a smooth surface, it is mobile, it is insensitive to touch, and it does not bleed on touch. And the site of origin here are the ethmoid sinuses. So these are the two inflammatory causes of nasal mass. Next, we move on to the tumors. Now, tumors can be divided into malignant and the benign ones. First, we'll talk about the benign tumors. So, the first tumor is squamous papilloma. The squamous papilloma usually has varicose lesions. If you know what skin warts look like, that's exactly what it looks like. But this happens in the nasal mucosa. And they can be single or multiple. It's sessile or pedunculated. And the usual site of origin is the nasal vestibule and the lower part of the nasal septum. So this image shows the squamous papilloma. It is not a very good image, but roughly this is what it looks like. Next, we move on to inverted papilloma. Inverted papilloma is a case that you very commonly get in your practical classes, and this inverted papilloma has a very distinct appearance. You can see in the image over here, it looks like a soft mass, pinkish. It can be pinkish or it can be grayish. You can see in both the different images here. This is a grayish mass, whereas this is a pinkish mass. Both of them are inverted papilloma. It'll be a very fleshy mass. You can see it, how fleshy this mass is over here. This mass is usually friable. It bleeds on touch very easily, which means that it is a very vascular tumor and it is insensitive to touch. This insensitive to touch, this is a point that differentiates it from the malignant tumors. Malignant tumors will usually be sensitive to touch. And what are the common sites of inverted papilloma? The most common site is the lateral wall of the nose in the middle meatus. The less commoner sites are the other sinuses like the maxillary sinus, frontal sinus, or the ethmoid sinus. And in history of these patients, you would usually find a history of HPV. These cases are more common in males than in females, and it is more commonly seen in the fourth to fifth decade of life. Now, inverted papilloma has two other names. One is Ringer's tumor, and the other name is Schneiderian papilloma. So, inverted papilloma is something I will cover separately in a separate video because it has a lot to be discussed in it. But for now, we'll move on to the next tumor. The next two tumors that we'll discuss are the hemangiomas. First is the capillary hemangioma. Capillary hemangioma presents with a soft, dark red, pedunculated or sessile mass arising from the anterior part of the septum. It is important to remember this. It always arises from the anterior part of the septum. And as the name suggests, it's a hemangioma, so it will be a vascular tumor, which means that it will bleed heavily on touch. And these masses are usually very smooth in the surface, but sometimes you may find ulceration on the surface as well. Capillary hemangioma, you can see in the image over here how reddish it is. It's like a soft red, dark red mass, very vascular mass, which will come from the anterior part of the nasal septum. Capillary hemangiomas are also known as the bleeding polypus of the septum because it's a polyp like structure that comes from the septum and it is very vascular, so hence it is always bleeding. The next tumor is cavernous hemangioma. Cavernous hemangioma is very different from capillary hemangioma in terms of the site from where it arises. Now, it usually arises from the turbinates on the lateral wall of the nose. And cavernous hemangioma, you can see in the structure here, it is a reddish or purplish mass. And obviously, as it is an hemangioma, it will bleed on touch. You can see the image over here. This is the nasal septum, and this is the middle turbinate over here. And somewhere in between the two, there is this cavernous hemangioma, and it most likely arises from the middle turbinate on the lateral wall of the nose. Next, we move on to the next tumor, which is angiofibroma. Angiofibroma is a globular, pinkish, smooth mass. You can see in the image here how globular it is. It is very pinkish. You can even see these vessels on top of the mass, on the surface of the mass. This will be firm in consistency and it is a very, very vascular tumor, so it will bleed on touch. And as I've mentioned, there will be vessels on the surface. And on posterior rhinoscopy, sometimes you'll see the mass filling up the nasopharynx. And if the most common site of angiofibroma is the spinopalatine foramen, and very rarely it may also arise from nasal septum. And a very key history point that you will see here is angiofibroma is very, very common in adolescent males, males reaching their puberty. So, puberty, about a 13 or 14-year-old boy presenting to you with epistaxis, complaints of epistaxis, or bleeding from the nose, profuse bleeding from the nose. The first suspect you should have is a juvenile nasal angiofibroma. Next are a few rare causes of benign tumors in the nose. The first one is schwannoma. Schwannoma is usually a rounded nasal mass which will be firm to rubbery in consistency. You can see here it is a little bit yellowish in color, and you can see here that there are some blood vessels on the surface. This may or may not be there, but there may be some blood vessels. And the site of origin is usually the ethmoid, maxillary, or the sphenoid sinus. It is a very uncommon tumor arising from Schwann cells of the nerve sheath. The seventh benign tumor, is a chondroma, which is a very rare tumor of the nose. It is usually a smooth, firm, lobulated mass, and the site of origin are the ethmoid sinus, nasal cavity, and the septum. And lastly is the pleomorphic adenoma, which is very, very, very rare in the nose, and the site of origin is usually the nasal septum. Next, we'll talk about the malignant tumors of the nose. So, when it comes to malignancy, first I'll tell you there is a general description of the mass that you will see in all malignant tumors. And then, if you have to differentiate in between the specific type of malignant tumor, there are certain history points, and then there's histopathology, which and certain clinical features which will help in differentiating between the specific malignant tumor. But the generalized description is malignant tumor or a malignant nasal mass will be looking like an irregular pinkish or grayish mass with everted margins. You can see in the image, this is a grayish or lightly pinkish mass, very irregular in shape with everted margins. It'll be a very friable mass, bleeds on touch very easily, sensitive to touch. And this is a point that helps in differentiating from inverted papilloma, where you will see that those are insensitive to touch. It'll be firm in consistency, and sometimes you may see ulceration. So this is the description. These are the signs that you will be looking for when there's a malignant tumor. Now we'll talk about the different malignant tumors and how specific point will help you in pointing towards the direction on that tumor. The first one is squamous cell carcinoma. Squamous cell carcinoma is the most common malignant tumor of the nose. Usually, you'll see it happening in the sixth or the seventh decade of life, more common in males, and the site of origin are 50% cases you will see that it arises from the lateral wall of the nose from the turbinates. It can be seen in the mucocutaneous junction of the septum and the lateral wall of the nasal vestibule. Second most common nasal malignant tumor of the nose is the adenocarcinoma. Adenocarcinoma also can be seen in the same age range and also more common in males than females. The very different association that you have to remember here is adenocarcinoma is associated with woodworkers. So, if there's any history of a person having an occupation in the woodworking industry or been exposed to all of that, it will more likely suggest adenocarcinoma. And the site of origin is ethmoid sinus and the nasal cavity. And adenocarcinomas are usually cancers that have very slow growth and they rarely metastasize. Next, we move on to the next malignant tumor, which is adenoid cystic carcinoma. Adenoid cystic carcinoma is the most common minor salivary gland tumor that you will find in the nose. And here, a differentiating feature you got to remember is that it is more common in females than in males, unlike in squamous cell carcinoma and in adenocarcinoma. This is also a tumor which grows very slowly and it has early perineural and vascular spread, and site of origin is the maxillary sinus. Next one is esthesioneuroblastoma or olfactory neuroblastoma. This is also a tumor which is more common in females and it has a bimodal distribution, which means that it shows peak in two different ages. One is at 20 years and another is at 50 years. And this is a tumor which arises from basal cells of the olfactory neuroepithelium. Another test that will help you in differentiating is these tumors usually expresses neuroendocrine markers like neuron specific enolase or NSE, synaptophysin, and chromogranin. Next malignant tumor is the melanoma. A melanoma has a slightly different description from the rest of these malignant tumors. You can see in the image right over here, it is a polypoidal fleshy mass in nasal cavity, which may be solitary or multicentric. And the mass can be heavily pigmented, appearing black, or it may appear pink when it is an amelanotic melanoma. And the age group where this is common is the elderly age group. And again, this is another one of the malignant tumors which is more common in females than in males. The usual site of origin is the anterior part of the nasal septum and the inferior turbinate. Next is hemangiopericytoma. This is the last malignant tumor of the nose that we'll be talking about. This is a very rare vascular tumor and it originates from the pericytes of the outer capillary wall. It is usually again seen in the elderlies in 60 to 70 years age group. It will be a soft gray polypoidal mass in the nasal cavity which will bleed profusely on touch. As you can see, this is a hemangiopericytoma. So these are all the malignant tumors of the nose which presents as a nasal mass. Next, we move on to the next group of causes, which is granulomatous diseases. Again, granulomatous diseases was divided into specific and non-specific. Specific can be divided into bacterial and fungal. So the first bacterial cause is rhinoscleroma. Rhinoscleroma, different you'll have different clinical features or different appearance depending on the stage at which it presents. Rhinoscleroma has three stages. First one is the atrophic stage, which will have a image which is more resembling atrophic rhinitis, where things like the inferior turbinates, the septum, everything starts getting atrophied. There'll be roomy, large nasal cavities full of black crusts and discharge in the nose. So that would be the atrophic stage. The second stage is the granulomatous stage, and this is the stage in which you'll find a little bit of a nasal mass scenario over here. You'll find that there is granulomatous nodules in the nasal mucosa, and these nodules are usually painless and non-ulcerative. And the third stage is the cicatricial stage, where basically everything undergoes scarring. And this scarring leads to stenosis formation. So, more commonly, you'll see stenosis in the nares in these cases. And what is rhinoscleroma caused by? Rhinoscleroma is caused by a bacteria which is a gram-negative bacillus, and it is called as Klebsiella rhinoscleromatis, also known as the Frisch bacillus. And there is no age or sex predisposition here. It can happen in any age, any sex. Usually, it starts in the nose and the nasopharynx, and from here, it can spread to other places like the oropharynx, subglottis, trachea, or the bronchi. And this is a case which is more similar in northern part of India as compared to rhinosporidiosis, which is more common in southern part of India. And there's another particular sign that you see is called the Hebra nose. Hebra nose is seen in the granulomatous stage of the disease when the nose kind of gets a hard woody feel. You can see in the image here there is nasal deformity and the broadening of the nose happens and it becomes kind of hard. That is known as Hebra nose. This woody feel of the nose. So, this is about rhinoscleroma. The next bacterial cause is the tuberculosis. But tuberculosis is a very rare disease happening in the nose. But in case it does happen, it starts from the anterior part of the nasal septum and anterior end of the inferior turbinate. Usually, what happens here first, there will be nodular infiltration, then there will be ulceration, and as a result of this ulceration, because it arises in the anterior part of the nasal septum, there will be perforation in the cartilaginous part of the septum. Next bacterial cause is the leprosy. The site of leprosy will be the same as that of tuberculosis, and it will be seen in the anterior part of the nasal septum and anterior end of the inferior turbinate. There can be excessive nasal discharge and red and swollen mucosa seen over here. As a result of this, there will be nodular lesions forming on the septum, which can ulcerate and then cause perforation. And ultimately, these are the features that you will see. There will be atrophic rhinitis, depression of the nasal bridge, and columellar retrusion. So, this is leprosy. And the last bacterial cause is syphilis, where usually what happens is a gamma formation happening in the nasal septum, and septum will get destroyed in both its bony and cartilaginous parts. These are the four bacterial causes of granulomatous diseases of the nose. Next, we move on to the fungal causes. The first fungal cause is rhinosporidiosis. This is again a very, very common scenario that you will be seeing in your practical cases, and it has a very different, unique appearance. So, the appearance you can see in the image over here, if we had to describe looking at this, it looks like a friable red polypoidal strawberry like mass, which is studded with sporangia, which you cannot see over here. Sometimes you'll see that there are some white dots on the undersurface of the mass. Those are usually the sporangia. And this mass looks very, very vascular. So, this will bleed on touch, and this happens due to the formation of granulation tissue. And the usual sites where this disease starts is the nose and nasopharynx, but there are other sites that can be included as well, like the lip, palate, conjunctiva, larynx, trachea, bronchi, skin, vulva, and vagina. And rhinosporidiosis is something that is more common in young males. And there might be a history of bathing in pond water from which they catch this fungus or protozoa, which is known as Rhinosporidium seaberi. Rhinosporidium seaberi is the cause of disease called rhinosporidiosis. Now, this is about rhinosporidiosis. The next fungal cause is mucormycosis. In mucormycosis, you'll see a very black necrotic mass filling up the nasal cavity and eroding the septum and the hard palate. I have one video that I have recorded on mucormycosis. You can check it out for more details over here. So, the main differentiating feature here is that you will see a black necrotic mass, and this mass will erode the septum because it is a very invasive disease. It will erode the septum and the hard palate. Next, we move on to the non-specific causes of granulomatous diseases. The first one is sarcoidosis. In sarcoidosis, what you see has a strawberry skin-like appearance. You can see in the image over here, there are some granular appearance, small erythematous mucosa. This is outside the nose, but this is a similar appearance that you'll see within the nasal mucosa. It'll have a characteristic granular appearance, which is referred to as strawberry skin because of the tiny pale granulomas against a hypertrophic erythematous mucosa. And this is usually very friable, and the common site over here is the anterior nasal septum. Last granulomatous disease that can be causing a nasal mass is the wedge nose granulomatosis. However, this is a very destructive disease, so there will be destruction of all the intranasal structures like the septum, turbinate, sinuses with formation of a single large cavity, and there can be septal perforation and nasal collapse. The next group of cause that will move on is the fungal sinusitis, or more specifically, allergic fungal sinusitis. Now, this is a disease where in inflammation which is happening because of a fungus, there's also an allergic component to it. You will see that these patients come with unilateral or bilateral nasal polyposis with thick, sticky, yellowish or greenish mucus. You can see over here, and this is known as the allergic mucin. An allergic mucin has the appearance of having very similar looking to peanut butter. So this is also known as peanut butter like mucus. And this is usually a young patient presenting to you with the following description of the nasal mass. Last of all, we'll move on to the miscellaneous causes of a nasal mass. And there are three causes. The first cause would be a hypertrophic inferior turbinate. This is actually normal structure that we have in the nose, in the lateral wall of the nose. In cases of allergy, what happens is the inferior turbinate undergoes a lot of hypertrophy. So as a result of it, sometimes we can see a soft pinkish mass in the nose when we see an anterior rhinoscopy. You can see the image over here. These are soft pinkish mass, but it seems to be arising from the inferior part of the lateral wall of the nose. And a very important distinguishing feature would be if you put nasal decongestant on this mass, you will see that it undergoes shrinkage due to vasoconstriction. And that will help you in differentiating it from any other nose. Because when you are having allergic symptoms, if you use a nasal decongestant, you'll see that the nasal obstruction that you were feeling disappears completely or it reduces a lot. So that is a very differentiating feature. And also, this mask is not mobile and it will be sensitive to touch. Next is rhinolith. What is rhinolith? Rhinolith is basically a stone-like formation within the nasal cavity. It will now, what is the appearance? It will look like a grayish brown or greenish black mass. You can see in the image there with a very irregular surface. You can see that it has a very irregular surface. It is very stony, hard in consistency, and it will be located in between the nasal septum and the turbinates. This structure is usually very brittle and it can easily break on manipulating. So this is how a rhinolith will look like. And the last of all, the last cause was a blob of mucus. Sometimes you may get confused seeing a huge blob of mucus, and it may seem like as if there is a nasal mass in there. The only thing that you need to do is use a suction and remove the remove the mucus, and you'll see that most of the times it will just disappear, and there's actually no nasal mass. So that's something you should not completely forget about, because sometimes when we see when we see a symptom, when we see a mass, we always think of all the pathological causes. Sometimes it can be just a very normal, simple, normal thing which does not have to be any pathology. So, this was all about the differential diagnosis of a nasal mass. I have not discussed about each of the conditions in details over here. This is just for the clinical appearance of each of the nasal mass causes. And I'll be covering all the details about the different causes separately in different videos. That's all for today. If there's anything you want to know about today's topic, please write down in the comment section and I'll get back to you about it. Thank you.